Hello, good evening everyone, and welcome to the EUROGEN webinar series. And this webinar is part of our colorectal webinar series, which we do in collaboration with ERN ERNICA. So just before we get started, I'd like to take a couple of minutes to explain a little bit about what an ERN is and does. So EUROGEN is one of 24 European reference networks created and funded by the European Commission since 2017, and they cover all different medical fields. In EUROGEN, we cover rare urorectogenital diseases and complex conditions. So all types of diseases and conditions which need highly specialised surgery, where the expertise is rare. So some activities of our reference network, well, we do virtual consultations, and I hope you took note of the slides at the beginning. We have a new tool that has been developed by IBM. It's been upgraded recently. So we have the capacity to conduct virtual consultations across border. So the knowledge can travel between our experts and not the patients. Now, this service is completely free to any healthcare professional working in the EU. So please, if you do have a tricky case and you'd like some advice or able to discuss it with people in several hospitals, please don't hesitate to get in touch and we can give you access to the system very easily. We also collaborate on writing clinical guidelines together. And another very exciting development is we are creating a EUROGEN patient registry. We all know that the data for patients with rare diseases is fragmented and scattered across many countries. So if we can pull together the data and evidence in a single registry, then we will have evidence going forward for the clinical guidelines, and also it'll be very, very important for future research. And finally, I'd just like to mention our fabulous book, Rare and Complex Urology, which is a collaboration across the whole network. So it's the latest scientific knowledge on all the disease areas that we cover. So moving on to tonight, we have a very interesting topic, anal lipofilling, when, why, how, outcomes and ethical considerations. And our presenters here this evening, we're honoured to have with us tonight Professor Ivo de Blaauw, who is a professor in paediatric surgeon at Amalia Children's Hospital in Radboud University Medical Centre in Nijmegen. And we also have Dalia Aminoff. One of the unique features of our reference network is the fact that we work hand in hand together with patients. And Dalia has been on our patient representative body since the very beginning. We also have Vincenzo Davide Catania, who's a paediatric surgeon at the University Hospital in Bologna in Italy. And we also have Maria Vegter, Assistant Professor in Ethics and Philosophy of Medicine, again at Radboud University Medical Centre in the Netherlands. So thank you again to all our presenters for sharing their expertise. And for the attendees, this webinar is eligible for EACME accreditation for those who attend the live webinar and complete the post-session survey within 2 weeks. It's supported by the ARMNet and EUPSA also. So I'm going to hand over now to our presenters, and I very much hope you enjoy the webinar. Thank you.
Yes. Just waiting for everybody to arrive or not, or shall I just start with that? I'll start with the introduction. Welcome everybody with this webinar on lipofilling and anorectal malformations. A little bit controversial, but also new. And today we will not only talk about the technique and pros and cons maybe, but also some ethical concerns. And I also ethical concerns on when to start a new technique more in general, I guess, and hopefully also some kind of framework how to deal with it. First, Vincenzo, we'll start
Yes.
this presentation, and I think everybody is here now. Vincenzo, please share your screen, and then we can start.
Good evening to everybody. I'm going to share my screen. Just a second. Here. Can you see?
Yes, we can see.
Just
we can't see the presentation yet, but you are sharing something. Yes. Maybe now you have to put it on. Yes, thank you.
Okay.
Caricamento means slowly.
Loading, yes, yes.
Okay.
I mean, now you can see everybody. Okay, so good evening to everybody, and thank you for the opportunity to present our experience into this technique. I'm talking on the behalf also of the Professor Lima, who is the director of our school and our pediatric surgery unit. And a few years ago, we tried to implement our treatment for patients who had experience of fecal incontinence after arm reconstruction. In particular, intersphincteric autologous microfragmented adipose tissue is a novel technique. For convenience, we are going to say anal lipofilling, just because the name is too long. So, first of all, I have no conflict of interest also with the pharmaceutical product which is used to extract the adipose tissue. So, as you know, fecal incontinence is one of the main concerns after anorectal reconstruction. It impacts also on social acceptance of the patients, had an important impact also on the psychological and and impacts also on the quality of life. Often it could have an impact, in particular in patients who are around pubertal age, so at the starting of the acquisition of the sense of themselves, the sense of shame. So sometimes if they are not dry and clean during the day, they could have a dangerous impact also on their quality of life around the social aspect, but also the school aspect. So the fecal incontinence, which is the ability of control the bowel movement, could range from a small amount of leakage of feces, of stools, or to a completely loss of sense of control. So, as we know, it could be the consequence of many pathologies in children, as the consequence of congenital malformation, as anorectal malformation, who could be also worsened by neurological defect that could also affect patients who had already anorectal malformation, but also patients with different disease who concern the gastrointestinal tract. So the first step usually is to have a correct diagnosis of these patients. The first step is usually have to, it is also the dialogue of the patients, the access to the outpatient, the importance of having a follow-up, which is very strictly, very, I would say, standard, that include temporary visit to check how the bowel is working and how we could manage even the first sign of incontinence, because most of these cases are encountered also in emergency department because there is a lack in the frequency of the access to the outpatient. So these patients maybe are lost at the follow-up. The second step is, which is recently introduced as our routine practical diagnostic step, is the endoanal ultrasound. As you can see, we wrote a book also with the help of the Giovanni Ruggeri who described this novel technique, which is implementing in the understanding not only for the normal anatomy of the internal and external sphincter, but also in case of previous surgery where this anatomy could be distorted also and could have some scars that could have an impact, direct impact on the function of the anal canal. MRI, anorectal manometry, and the last step, but I would say is one of the first in the evaluation of patients, is the use of a scale to categorize the patients. The most common use and most recent is the Klickenbach scale, but sometimes it could miss some patients. So I would say the real difference is made when we are approaching to patient having a dialogue with the patients, so listening by their conditions, their needs, and these allow us to understand where there is the problem and how we could impact on the management of the fecal incontinence. So the anal lipofilling is also the last step of the treatment of these patients. Before of that, there are many treatment based on bowel management, which could be also based on diet, but also with electronic systems as Navina or other similar to that, that could help a patient to keep clean and dry, perineal biofeedback, and as I said, lipofilling as one of the novel therapies. I won't to bother you too much about the technique, because we could find also on the PubMed or other sources. But the concept is that the tissue, the adipose tissue, could be used as a source for repairing in many disciplines. It has been used in orthopedics or in other disciplines, because the autologous adipose tissue has the positive effect that we could extract from that amount also not only of tissue in itself that could have a mass effect in case of repairing of a missing of a vacuum or a missing scar or something like that, but it could contain also a good amount of stem cell that could have a positive impact on repair in different conditions. The main limit is that it has got a time-limited effect, because the reabsorption of the adipose tissue is estimated around 40 to 50%. So this is actually the main limit. In our experience, I would to share how we perform this procedure that is usually performed in very selected cases, and it is performed under general anesthesia in operative room. So we performed a retrospective evaluation around our experience in ARM patients, and we selected few patients that were amenable for this technique. Actually, we evaluated these patients as patients who had important fecal incontinence, but I would underline that all these patients had the presence, still the presence of voluntary bowel movements. So they felt the movement of their bowel, so they could keep the continence. And I would underline this aspect because these therapies are, focused on patients who are considerable as a good prognosis. So patients who could have the capability of keep their stools. Most of the cases are patients that are out from the follow-up, or patients that I would say denied their condition, so they are not attending so strictly their bowel management. So sometimes are patients who are not so focused on their condition, and like in a case that they don't want to accept their condition. So in most of the cases, those were patients that had the potentiality to keep a good continence, but for some reasons they are out from the good outcome. So going deeper into the technique, during the access in the OR, we performed the ultrasound to check the anal canal, to check the internal anal sphincter, and to see where if there is an incongruence or if there is a scar into this. After that, we start with the anal lipofilling. Before it is an injection of epinephrine, after 10 minutes, we are going to perform liposuction. Usually it is performed with the help of the plastic surgeons who have a great experience in this technique. After that, the adipose tissues is processed, and once it has been cleaned, we could extract around 30 millimeters of pure adipose tissue, which is used for the ultrasound guided injection. Usually we perform between 3 or 4 injections into the anal canal, always under the guidance of the ultrasound. As you can see here, the thick point where we put the adiposal tissue. In our experience, as I said, we performed 8 procedures. All of them were males, and in 6 cases were recto-urethral fistula. The mean age is quite significant because it are all boys, in teen boys, so they are around 13 years of age. So in that time where they are, I would say, starting to take care by themselves of their bowel, but they are not so deep into their conditions, so sometimes they refuse to manage themselves. So it's quite interesting considering that in that case most of these patients are not more amenable to manage themselves just with bowel management. Also, if they use already Navina. Their previous history was of colostomy and SARP regularly performed between 2 or 6 months of age, according to their condition, and all of them experienced severe incontinence on the follow-up. Usually, the procedure is repeated for each patient with a mean of 2-3 times. Here are the preliminary study of the first 4 patients, and in most of them, we observed a significant reduce of soiling during the day, except for 1 patient. So, moving to the conclusion, consider that it is a preliminary experience on this field and also on this technique. We consider, as we said, fecal incontinence one of the major problems in patients already operated for anorectal malformation. The positive aspect of the anal lipofilling is the mass effect that it that we could obtain in the rather after the injection, because it could improve the sense of continence of these patients. As I said, the adipose seminal cells who could improve the result also on long-term follow-up. I would underline the importance of ultrasound guidance to be more precise into the injection. The main limit is already, as I said, the time-related efficacy. And I would underline that it could be a very personalized treatment. So it is not offered to everybody who came to our outpatient who had experience of fecal incontinence. So our patients who could not be managed just with regular bowel management. So in that case, it's a starting point also to improve their sense of care of themselves. And in most of cases, those treatments are repeated 2 or 3 times, but the effect is not only the effect of just the injection, but the I would say more in general, the sense or the increased sense that these patients acquire of themselves, or the condition they could have a problem and they could improve their quality of life if they work on themselves, on the bowel movement, on the fecal consistency, and improve their quality of life. So in most of the cases, we are going to we performed around 3-4 injections, but in other cases, after 1 or 2 injections, we could observe also good results that are connected not just for the injection in itself, but also with the more adherence to a follow-up program that we observed in these patients. Thank you.
Thank you, Vincenzo. I will stop sharing. If you stop sharing,
okay,
then I will continue sharing. There are already some questions, but we'll get to that later.
Yes, as a video buffering.
Hold on, and then I will share my screen. Of course, takes a while.
Okay.
I think.
Yes, you are sharing your screen indeed.
I am sharing my screen, yes. Okay. So lipofilling, as I said in my introduction, is a bit controversial. And the reason why is because it's been tried for many years with other filling material, which didn't really succeed. So the question, of course, is how do we continue as well? Because, of course, there are a lot of developments, and lipofilling may be different than filling with other issues. But I'd like to discuss a little bit some of the concerns, not all of them, but some of the concerns, and people can react in the chat as well. And we will try to put it in a bigger picture as well. First of all, I do have some disclosure. At least I'm one of the coordinators of EUROGEN, so I feel maybe a little bit differently in responsibility of this. And I'm also the disease area coordinator, so I do have some opinions, but I'd also like to give everybody the room to speak up and say, particularly on new treatments. Now, listening to your talk, Vincenzo, and also reading some of the papers, my first questions, of course, are the patient selection. For me, it's still a bit unclear why these patients don't function with bowel management. What has happened before? Should it have been adapted? I also miss a little bit the data on how to select them, because you are filling part of it, and maybe these stem cells are working, but we don't know. Maybe it's a mass effect. Maybe it's a stem cell effect in the future. On the other hand, I also read that people think it's more like fibrous tissues, what ends up, which all means that you kind of make them obstructive, stenotic. And we all know that in anorectal malformations, it's about sensitivity that is less, with tethered cords and other ways, just a development story. Muscles that can't hold the stool, and the motility plays a role, because many of them are obstipated. They already have a difficulties in an outlet. So the choosing of these patients in urethral, particularly the perineal fistulas, for me is still a bit unclear. And this relates then to starting such a study. What should we write down or not write down? So some additional data are somehow missing. If we look at the outcome, you use the Quickenback. Well, the Quickenback is very surgically made. It's not validated, and certainly doesn't say anything about how you dealt with what the continence was, why somebody is incontinent, or how it helps, because you need other scores, other systems to exactly look at it. And particularly when you start a new study or something, new treatment, which is kind of experimental, I think my feeling is that you should have a lot of data before you start, both on selecting the patient, but also in the outcome. So the third thing, of course, it is minimal invasive. I see that, although if I see your picture, you have to get a lot of fat, and I know complications of fat embolisms, and I know in liposuction patients, adults do die after surgery, and there has been a case of embolism after a paraurethral injection for urinary incontinence, has been published as well. So I'm not sure if everything is known of the side effects. If we use if it is a stem cell effect, for example, what are the long-term consequences of putting stem cells besides of the rectum? What are the long-term consequences of stem cells anyhow in a child of 4 or 5 years in relation to the development of cancer or anything? Do we know anything about it? Is there anything known about it? Those are the thoughts I have with new studies. And I'm not saying that you shouldn't do it, but I think we should at least think about it. So the concerns, they continue a little bit because the long-term outcome is not really known yet. So why? Then my question becomes, okay, this is, of course, when you start a new treatment like this, you will never have a long-term outcome. And I hope Mira will give us some guidance in that as well, how to deal with it. But should you start with a child or should you start with an adult when you think about it? Because these children, they don't choose, their parents choose. They choose because they don't like their child to be incontinent. Is this fair after 25 years when they're 35 to say that we chose them? Is this the real true informed consent we want? The other concern I have, we all know that the size of the fat decreases, or we all know it's been described. So you have to repeat it. So how often? Do we know anything about it? If I look again at the systematic review, at the literature, the Cochrane clearly says, and this is an older one, I know, that there's no benefit. There's only one study that compares conservative treatment with of incontinence in adults with filling around the rectum, and it talks about short-term outcomes. What the Cochrane clearly says, all studies don't have a solid methodology, which means they're all pilot studies. It means that many of them, we still don't know the long-term outcome. The reviews from 2013, but nobody published the long-term outcome. For me, that it is a bit worrisome. And the other thing is, and it's a bit difficult, but some of the papers are published in Children, which is a magazine which we now, and I published in Children as well, but it's one of the predatory journals. So they review it not thoroughly. So I think if we do these kind of things, we should try at least publish them in very well recognized papers to have it a solid background to continue it. Otherwise, it will only be a pilot. So the other question I have, so how should we do this? And that's probably the next talk is what do we monitor? How do we deal with this when we have just limited data? Because I do think incontinence could be a problem we may want to deal with. The other issue is how do you get the informed consent? I always find it difficult. If I don't have the data, I do something relatively new, don't know the long-term outcome. As pediatric surgeons, how do we deal with this? Because we don't want to lie, but somehow we kind of lie because we don't know the long-term outcome. We don't say exactly what is happening. And if I look at, and I'm a very simple medical ethicist, I'm not an ethicist, but the 4 things that is medical ethics are about is very simple. We should be beneficial. Now, I think we are, but is bowel management maybe just as beneficial? We should don't do no harm. And then I am there, okay, stem cells, complications. But on the other hand, it is very little invasive, we say. I just discussed about the autonomy of the patients, the parents, but this is also, if you want to be autonomous, you have to be well prepared with good informed consent to say, okay, I'd like to have this therapy. And not just saying, okay, I can't treat your incontinence. And the other final thing is that, of course, we need equality of care, but that's, maybe this is a bit too far from this topic, but we should try to treat all the patients the same, which of course, this is a selected group. So I think there's a lot of other things to be said. So those are more my ethical concerns, which are very surgical and short. And therefore, I'd like to have a better discussion maybe about it, or guidance by Mira to see how we deal with it. Okay?
I think that's my sign, right? I can.
That's your sign. And I
yeah.
have to stop sharing. Yeah. Okay. I just did, I think.
Yes.
Thank you. I'll just quickly take my slides in and then I'll say something more and introduce myself. Yeah, are you?
Yes, you are sharing. And now if you could put it in presentation mode, then it's all perfect.
Yes, we're good to go.
This is your speaker notes, so you need the other.
Okay, thanks. So,
I think if you just, yeah.
That's the one.
Or what you can do is stop sharing and then put the slides in presentation mode and then select the screen which shows the presentation instead of the speaker notes.
Thanks. Yeah. So, second.
Yeah. And in the meantime, I would like to mention that Vincenzo, for me, your video, your webcam stopped. So I'm going to try something here.
And we can
no, unfortunately.
Answer one of the questions maybe as well, because I see one question.
I like the sharing of the video. I'm trying to reboot the webcam. Let's see. I don't know. I will try to stop and to reactive. I will check it.
Yes, yes.
Okay, Mira.
Are we good to go?
Yes.
You're good to go.
Okay, thanks. So thanks for inviting me here to talk a bit about my expertise on ethics of newly emerging technologies. My name is Mira Vegter. I work in philosophy and ethics of medicine as an assistant professor. And what I look into mostly is newly emerging technologies, or in this context, techniques. Just as a quick disclaimer, I have no expertise in pediatric surgery or urology. So please... But what I do think is that my take on, because I'm very much familiar with this in a lipofilling, I do think my work might shed some light on how to tackle the issue of uncertainty. What I will do is explain three concepts or ways of going about this problem, which might help think of solutions on how to, in more general, deal with innovation in pediatric surgery in a broader sense. So I'm going to start talking about the Collingridge dilemma, and then I'll explain how we can discriminate between uncertainty in terms of long-term outcomes, but also normative uncertainty. What is the good thing to do here? And then basically I will end by talking about anticipatory governance, ways of guiding the process of innovation in a way where you can repeatedly involve stakeholders so that ethics becomes integrated into the innovation process. And this is all food for thought, and I'm looking forward afterwards to discuss how this might apply in the case of pediatric surgery and the anal lipofilling. So this is a classic idea, the Collingridge dilemma, and it's very simple, but it's also very paradoxical. So if you would take a new technology, intervention, or technique if in a very early stage, when the idea is born and you start testing or trying something out, there's very limited knowledge about what it will do in the long term, what the effects are and what to do, and how it will work, perform best. On the other hand, there's a huge amount of control. You're either the first or you're at the best in your kind with certain knowledge to do so. So you can determine whether or not to do this and develop this further. Well, on the other hand, if we were to follow innovation on the long run, let's say, so a classical example is, say, a smartphone in society. At the early stage, you could still control where and who's using it. By now, you can't at all. So basically, if a new technique or technology is implemented on the long run, there's no way you can control where it's used, how it's used, and how it should be used. Although there's much information on the long-term effects, there's a lot of empirical data of how it's working and also its social and ethical consequences. So a lot of ethicists and philosophers and of technology have thought about this issue. So just to sketch out the Collingridge dilemma in this case, to say the long-term effects of anal lipofilling in children is unclear, it's early stage. But if we were to go along all the way, in the end, we adopt this more broadly, then it would be hard to regulate. So the idea of this, how to tackle this dilemma, is to seek anticipatory governance. So it's both backward-looking and forward-looking, and involves stakeholders to deal with uncertainty. So I want to dive into the concept of uncertainty and sketch out the following. So when we talk about factual uncertainty, in complex decision-making, there's always the question, what is likely to happen if particular measures are introduced? So, and that's simply saying we don't know yet. It's something we can do by doing more scientific research, say. But scientific knowledge about the effects may be either incomplete or uncertain, and waiting for complete and fully certain evidence is not a good idea. So take the teen boys who are incontinent. Yeah, it might not be in their best interest to wait. On the other hand, with many new technologies, there's always the issue with hype or big expectations and promises, and I'm not suggesting there's an intention there, but I think as researchers and the way research is funded, we are always inclined to be optimistic about these new innovations. So there's still only after new technologies or decisions are made can we really say something about it. This is basically what I mean when I talk about factual uncertainty. On the other hand, we can also talk about normative uncertainty, and it asks the questions: is the proposed measure ethically and socially acceptable? And then there's more uncertainty there, because you would argue, well, there are normative frameworks deciding what's good, what's ethically sound, depends on our frameworks, and these evolve over time. Either do certain sentiments politically, but also because technology shapes our moral frameworks. This is what's called techno-moral change. I will not go into this today. Other hand, there's uncertainty about the interpretations of norms and values. So when Ivo says we should respect autonomy, well, how we respect autonomy, we could have many discussions on this, on what that involves and how this should be done. So even when we're saying the same, do we actually mean the same thing? And this adds up to the following typology of problems, I would say, based on this type of uncertainty. So, and I think what you could say, innovation, especially in pediatric surgery, adds up to what is called a wicked problem, in the sense that there's low factual certainty, but there's also low normative certainty on what is the good thing to do here. We have many wicked problems in our world. Basically, we can't agree on who's the owner of the problem and who should be doing something about it, who's responsible for the issue. So you could use the word wicked problems also for climate change, let's say. So this is a really broad term. But here, what we can learn from calling it a wicked problem is it demands from us as in being involved something else, rather than arguing about the classical medical ethics principles. We could say, well, perhaps we should organize our process differently, knowing that we deal with so much uncertainty, where we go back to anticipatory governance, saying how to deal with uncertainty. Well, we do the following. I suggest here the guidance ethics approach. This is also known as responsible research and innovation. There's all different types of way of going about, but I think the important thing is there's not a one-time moment where we decide this is good or this is not good. This is constantly negotiated with people involved. This should be done deliberative in the sense that what it means for these parents to talk about quality of life, for these teenage boys, what it means for them to face surgery, for surgeons to take risk, but also to see what is being done, etc. So we have to sort of negotiate also how we deal with this uncertainty, say factual, say normative. On the other hand, we have to be responsive. In that sense, I think a part of the success is saying, well, we build on our relations, and together in this network, let's say that's why we're here, we can be responsive to all types of ideas that should be negotiated when you go along with this practice. So, of course, there's different states, different ways and different phases to do this. What you could say is you could, in the guidance ethics approach, when you do research at an early stage already being anticipatory, involve families, patients, other experts in the field. So basically, the bottom line of my talk here would be that rather than saying we should have guidelines or have this external assessment of these new techniques, I would say, well, go for ethical accompaniment in the sense that you are constantly also talking about how to deal with the normative uncertainty here and ask those who have a stake. We should go for bottom-up ethics instead of the top-down formulation of principles. It helps to sort of together decide, well, this is what we should be talking. This is what is important here. So say trust of these patients in their physicians, or say, well, there's many different things that where I imagine Dalia has many ideas on this, on what people think is important. And I do think surgeons are very much capable of saying, well, this is specifically important for my patients. And what I like about this approach is that you're constantly putting a sort of looking at the horizon and say, well, this is what is now mostly important, and this is what we have to see what's working well, and also navigate quickly if you decide, well, this is not a way to go. But what I like as well, thinking about this guiding ethics approach, is that you would say, well, if we go for a new technique, we want to focus mostly on what we do want and not start by what we do not want. And that helps shape how we orient and anticipate this future where new technology is implemented. So that is my story for now, and I'll give the floor back to, I think, Ivo or Dalia. Thank you so much.
Thank you.
Thank you, Mira. It's also a lot of, for you, it's maybe very easy, but for me, I probably would have to hear it another time to really absorb what you mean. But I do feel that when we introduce a new technique like this, or anybody tries to do it, and everybody's allowed to do it for himself or for his patients, whatever. I'm not the one to say it. It's not, but I think if we as EUROGEN or something, we want to implement a new technique like this one, for example, we should do something like this if it's supported by a network which has more responsibility or etc. Also with the discussion, but maybe first, because you said about the patients, maybe first Dalia would like to comment maybe on both or three talks. I'm not sure what
Yes, I would like to comment on many things, and I would start from, let's say, what Mira said, which was very interesting. What the patients want, we all share the same thing. Patients want to be clean for 24 hours and not to soil. So, but this doesn't mean that anything can be done because they want to be clean. I mean, we are always, saying, okay, it's important to have innovative techniques, which is okay. But sometimes, for example, if I see what Vincenzo said about these patients, they have good prognosis, they are doing well, they have good potentials, they have only a perineal fistula. So why do they need to have something else other than a regular bowel management, which for them would be very easy? Sometimes we get a lot of patients that during puberty, for example, they don't like to do bowel management. They just refuse to do bowel management. So what is the solution to that? It's not to invent something new for them. It's to, for example, to interact with the patient organization or put them together in your outpatient clinic and they do all together bowel management. So they meet each other and they know who are they. They are not alone. They see each other and they know that it's something that everybody who has this problem can do. But something that I miss from the beginning is another thing. In the study done by Vincenzo and by their team, I miss, for example, the study on the bowel of the patient. I don't see any contrast enema to understand what is the colonic motility or any study of the sacrum, which may say how is the colon of the child. And therefore, I wonder why this patient should go out of the bowel management program and why the enema doesn't work to this patient, or I would like to say better that we all know that bowel management is not a solution for everybody, or it's a tailored solution. I mean, everyone has its own bowel management, has its own treatment according to his colon and to his motility. And I would like to remind to all of us that continence is done by three elements: good sphincters, good motility, and good sensations. If you have a good sensation and you put lipofilling in your patient, you create an obstruction. So I would like to know, have you ever done an ultrasound after a bowel movement that they had to see how much fecal material they have still in their bowel? I mean, do they empty well enough? Because the problem of being continent is not just to repair one of the three, is to have three of them together. So I really, sometimes we have patients coming to our organizations after a year of a new innovative, let's say, methodology for bowel management, and they are completely obstructed or they have pseudo incontinence at the end. This is what the surgeons came to the conclusion. So I really emphasize this to say that I'm a little bit concerned about new techniques or innovative techniques, because children in their puberty are very, naughty. They are not behaving like we would like to behave. And if you ask to a child who has diabetes, if he wants to have 2 injections per day will say absolutely no. And if you ask to a child with the anorectal malformation, if he would like to be continent without doing any bowel management with laxative or with enemas, he will say, of course, yes. But this is not the way we should put this. I mean, this is a different, I mean, we should invite the children in a different way. This is not the way it should be done. Thank you.
Thank you. Thank you all. I would like to open up the discussion.
Yes, we'll just
Maybe Vincenzo wants to react, or are we going to the chat box?
No, I think I can.
You can react if you want.
Okay. No, I would just reply to all your concerns, and mostly with them, I agree with your opinion. And unfortunately, considering the timing, I couldn't go deeper into the detail about diagnosis, about the follow-up that all those patients made. I wanted just to focus in general, because the first, as said by Dalia, the first point is that every treatment is personalized and tailored on each patient. So each patient had its own history, and considered we got a volume of around more 100 of patients, under literature, etc. This is a very small amount of patients, so very selective patients, sometimes with a family history, very difficult. Very particular. They were all studied by NIMA. They were all studied also by ultrasound, which is our focus actually, according with manometry. So those patients were selected because some of them were treated in other centers, so they had scars on the which has been supposed to be the integrum, internal sphincter anal. So my message was mainly close to what said Mira, so that if we are going to select few patients that we think that couldn't be completely amenable with what we actually have routinely in our hands, so are those patients that we are going to classify as good prognosis patients, because they have not sacral malformation, they are not neurologically impaired, but otherwise they are not working for their low adherence to the protocol, low adherence to diet, whatever. We are working, and they have few signs, or by manometry, by ultrasound, that could show a difference between other patients that had a more regular follow-up, a better outcome. This could be an opportunity, and this could be something that could be that didn't show particular complications. And I agree with Ivo that there are few studies that we are not aware 100% that there are no long-term consequences. We actually, based on experience made by adults and the use that they have done on other disciplines like orthopedics or like facial reconstruction, and we are based on that. That's true, but also in the meantime, potentially it could be a step, it could be one of the weapons that could be taken into the consideration during the dialogue of the patient. It is not offered as first option. I want to be clear on this. It is something that came out after months of dialogues, and it is not offered routinely. Every 6 months you have to do this and that. No, it is sometimes in a particular condition it is offered, and after we are going to check every 6 months, and if we are going to obtain good results, is not more offered to patients. So it could be a new window on something that could be used or taken to the mind as a potential therapy that could have potentially good effect based on what we are still studying on, which is the stem cell effect, which is an ongoing topic, very, I would say popular, but there are many studies on the potential effect of the stem cells, particularly those that were extracted from the adipose tissue, that seems to have the potentiality to differentiate in different kind of cells. So for sure, we should have long-term studies, maybe have a biopsy to see what this kind of tissue, how it could evolve, if it will evolve in muscular cells, potentially. We don't know, which is the point. But I totally agree with your consideration both, and I wanted to just say that we couldn't be so specific, because for each patient, it should have a presentation exclusively. Sometimes we need to summarize under number, but number does not describe the story of people.
But if you want to continue, if I listen correctly to Mira, what do you feel about this anticipatory governance structure? And maybe Mira, if you would want to give some advice how to deal with, for me, I would say, like, okay, please involve patients, patient groups, patient organization, also to have the discussion on, first of all, to prevent this colon-rich dilemma where we end up doing something we don't know, we still know whether it's good, but I mean, this is the moment to, with a small group, to see whether there is a profit or where there's not a profit. And later on, if you've done 100 patients, you will never stop, and nobody really will know probably whether it's of benefit or not, or what the harms are, and we're still waiting for long-term outcomes. And with the participation of patients and patient organizations or other people, and have a good interaction already starting at this moment, I think it will help to see in the patient selection, in whether it really is a profit, or whether it's like Dalia says, they're just adolescents who don't want to do the bowel management. And if you say, I have a quick solution, they will, of course, choose for the quick solution. Those kind of things. I think that is the structure you really kind of want in this new technique. Not to say, like Dalia says, don't do it, because there are many other ways. I don't, more or less. You say, okay, I'd like to do it because I have patients who really need it. And of course, there's some doubt. So I think somehow you should try to get together. I'm not saying that should be both of you, but somehow some kind of construction. But I don't know how Mira maybe thinks.
But maybe we should also wait for, Ivo, maybe we should also wait for long-term results. What do you think?
But that's 25 years. So that's the problem with innovation. But Mira will probably explain or try to, or you cannot always wait for the 25 or 50 years data I expect.
But 1 year and a half, like, to see what's happening with them, if they are not obstructed, for example.
But that's
long term.
Yeah.
I can quickly respond from the top of my mind. I guess what I think what Vincenzo describes is, if I understood correctly, that he's seeing these patients from time to time, and basically can it provides him with probably also argumentation when to and when not to, and I think that the difficulty is navigating. Is this actually a patient, and in this context, in this situation, that would actually benefit from this procedure? And does he know? Perhaps, I mean, if I understand Dalia correctly, the considerations are also sort of, if you sketch out these ideal situations, people don't know what they get into. But if you do so, and also understand with these groups what's important to them, and people do decide, well, I'm willing to give it a try, then you can very much weigh and have actually more information, more qualitative data, let's say, about what is important to whom when making this decision. So then you both have clinical reasoning and normative reasoning that will allow you to say, well, in these cases, it might be wise not to, and these cases, it might be interesting to look into this. And I think that's what I mean with this anticipatory governance, saying there's not a one moment where we're deciding, but that it's basically nurturing the innovation process in a way that you're moving ways you do want to be headed and moving away from where you do not want to be headed. And I think what Vincenzo so far sketches out, that these patients do in fact continuously meet with him, that might also help you consider how to involve new patients. Makes good sense. But there's of course also more expertise to be involved, which is, I think, another issue here.
I would suggest also maybe that the patient would be able to sign his informed or her informed consent, so they are able to understand what is going on and really participate in first.
Yeah, I quickly respond to that as well. Is there time? Yeah. So I think what traditionally informed consent has meant is mostly an emphasis on the voluntariness, so that patients don't feel that they are forced to decide something, and being a reasonable choice where physicians are inclined to explain very well that the pros and cons for certain decisions, right? And you want to check, does somebody reasonably articulate what he wants or not, and can he oversee what the consequences would be? But what we sometimes fail to consider is the authenticity of one's choices. And for that, you need to actually understand what's important to our patients, which means opening up questions about what does your life look like and why do you do certain things. And this might actually give you also sometimes arguments to do or do not do certain procedures. And I think these type of questions, you can only understand which type of questions need to be asked to your patients by also constantly having sort of either groups or people involved that actually understand the complexity of living with this disease.
Okay.
Thank you. I think looking at the time, it would be good to go to the questions from the attendees. There have been a couple questions in the chat. So if somebody can read them, then we can start answering them.
Well, the first one is I had a patient with an esophageal rupture and was admitted to Italy for stem cell therapy, which was never done for other reasons, which says basically is a statement that it's been used for other issues, I guess. Eberhard Schmiedeke has 3 questions. Did the patient show any change in the degree of constipation?
Yes, I have concern. I would say, just summarizing that those patients, for the first, they experienced an improving in the follow-up, and as I said before, not just for the lipofilling, but also for the continuous bowel management, because were selected patients who were already under management, and they experienced the reduced episodes of swelling from 2-3 episodes every day to 1 or 2 per week. And in cases of perineal fissura, those were referred to our center, so we didn't perform the first surgery. And obviously, most of our patients, concerning to the third question, are approached with psychotherapy and with a personalized bowel management program. So most of them, I would say 90% of the rest of the patients, consider the number, are managed in this way. And the last question from Francisco was about neurogenic incontinence. I would say we didn't try yet on patients who are impaired, because most of those cases, those patients are in more critical, I would say, conditions. So the adherence to bowel management program is sure more strict, and they use marinas. So usually, considering their condition, they're amenable to keep dry and clean concerning their conditions. So most of them use also the diaper. So we did not have experience, but it could be eventually proposed. But actually, those patients, I think, benefit of very strict program of bowel management.
Parmida, all the people that are watching can read the questions as well, can't they? Yeah.
They can. Just for the recording, it's nice if they watch it back, because the people that watch it back, they cannot read the questions, but the attendees are live, they can read them. Yeah.
People have to watch and read and listen. They cannot use it as an podcast, this webinar. Okay.
No. Yeah.
Okay. So I think this is the end of because we're running over time already.
Yeah, we are running a little bit over time, but I think we used it well to discuss all the different aspects of the webinar. So I would like to thank you all for being here and presenting. And for the attendees, thank you very much for being here and listening. As Michelle mentioned at the very beginning of this webinar, if you fill in the post-webinar survey, it will help us improve our sessions, but you will also get an EACME certificate after 2 weeks. So if you would fill that in, we will be very grateful. I would like to wish you all a nice evening, and thanks again for being here.
Thank you.
Thank you, everybody.
Thank you very much. Bye-bye.
Bye.